radiolucent lesions of the jaw today. Okay, so before we start discussing radiolucent lesions, there's a few points that we have to be aware of. First of all, almost all conditions are either radiolucent or radio-opaque, and some of them are both at different stages of their development. So when all these lesions fall into these two categories, many of them start resembling one another, and it could be tricky to properly diagnose a lesion based on an X-ray or even clinical diagnosis only. So a detailed description is crucial when we're communicating with the pathologist, because at the end of the day, a histological examination is always the most definite diagnosis. Now, describing a lesion, there's a few points that we have to talk to whenever we're describing any lesion in the mouth. First of all, the age and ethnicity. Now, some age groups or ethnicities are more susceptible to certain lesions than others. For example, you have strabism that happens mainly in kids that are 3 to 6. Number 2 is the site. So some lesions are exclusive to either maxilla or mandible, or even exclusive to specific areas only. For example, a radicular cyst only forms around the apex of non-vital teeth, and fissural cysts only form in the midline. So the site where the lesion is usually can give out some hints. Now, number 3 is the size. The size of the lesion isn't that important, just because when we're trying to diagnose a lesion, just because both malignant and benign could be either small or big. But also some lesions tend to stay exclusively small, and some of them tend to have a potential to grow if they're untreated, like an ameloblastoma, for example. Now, when we're talking about the shape and outline, this is almost the most helpful tool in diagnosing a lesion. For example, a radicular cyst is always round and unilocular, and a giant cell lesion is multilocular. Now, you're never going to find either or any way different. So also the outline indicates whether a lesion is benign or malignant, because benign lesions tend to grow slowly. Therefore, when they're growing slowly, you always see on the X-ray that they have a well-defined border. But malignant lesions tend to grow fast, and then they give you that moth-eaten appearance or ill-defined borders. Now, when talking about radiodensities and the internal structure, that's when radiolucent or radio-opaque plays a role. Now, radiolucent lesions occur because there's a decrease in mineralization or resorption or even loss of structure. And then you have the radio-opaque lesions. They tend to have an increase in the mineralization, in the thickness, or even there could be a superimposition going on. Now, the effects on adjacent surrounding structures is also important, because some lesions tend to affect the neighboring teeth or neighboring structures. So you could find that lesions could resorb teeth, displace teeth, or even delay eruption, like a dentigerous cyst, for example. Now, the time, we should always try and determine time whenever possible, but usually it's difficult because most of these lesions are asymptomatic. So neither the patient nor the dentist is usually aware when it started. Okay, so usually if we don't have a previous X-ray or sufficient medical history for the patient, we can't really compare, but it's also important. Now, there's a step-by-step guide to diagnosing a radiolucent lesion. So first of all, we have to describe the lesion, which was the previous slide. Second, we have to decide whether the lesion is, one, a normal anatomical feature. For example, around a radiolucent lesion between the lower premolars is usually the mental foramen. It's not a pathology or it's not an artifact. Second, is this lesion an artifact? Because sometimes if you have an overexposed X-ray, underexposure, it could give you some radiolucencies or radiopacities that really don't mean anything. The third one, which is what we're more concerned about, is pathological. Now, step 3, let's assume this is pathological. We have to decide what the lesion is. So it could be an infection localized to a periapical tissue, infection spreading within the jaw. It could be a cyst, tumor, giant cell, idiopathic lesions. This is what we're going to talk about today. Now, step 4, let's assume that what we're seeing is, we think it's a cyst because we could see the epithelial lining and it's radiolucent. We have to consider all the classifications and subdivisions of those cysts and look for similar radiolucencies. Step 5, for example, let's say we think this is a radicular cyst. We have to go search for the typical appearance of a radicular cyst, how it looks like on the X-ray. So you want to compare what you're seeing, what you're trying to diagnose, with other studies or other X-rays that you know for sure that's a radicular cyst. Okay, so now we're going to start talking about the radiolucent lesions. Now, this is an inflammatory odontogenic cyst. Usually inflammatory cysts develop from the epithelial remnants of Hertwig's root sheet and the rest cells of malaise. Now, this is a radicular cyst that usually happens between the age of 20 and 50. It's the most common cyst in the jaw. I'm sure all of us have seen this at our practices before. The site is the apex of non-vital teeth. It's usually between 1.5 and 3 centimeters in diameter. As you can see, it's round. It has a smooth and well-defined border, and it's radiolucent. Now, what this does is sometimes it could displace adjacent teeth. It could cause buccal expansion or even displacement of the antrum, depending on the size of it. In the second X-ray, you could see a radicular cyst that's extending between two. Now, a good way to actually know which one's causing it is doing a vital test, and the one that's not vital is usually the one that's causing it. It could be either a necrotic tooth or a tooth that had a previous root canal. Now, the second one is the residual cyst. This is a cyst that remained after the causative tooth was extracted. So it usually happens in patients that are 20 years or older. It happens at the apical region of the tooth-bearing portion of the jaw. So it's apical to where that tooth was. It's 2 to 3 centimeters, round, monolocular. It also has a smooth, well-defined, and usually well-corticated outline. It's radiolucent. It could also cause teeth displacement, buccal expansion, and displacement of antrum if it gets too big. Now, we're going to talk about the lateral periodontal cyst. Now, usually the diagnosis of this cyst, we reserve it for a cyst that's usually a periodontal region, but it's not inflammatory or an atypical keratocyst. So this happens in adults over 30 years old. It's rare. It happens on the lateral surface of the vital teeth, most common in the bottom canine to premolar region, like you can see in the X-ray, or upper between the lateral incisor area. It's usually small, less than 1 centimeter. It's round, monolocular, has a well-defined and smooth outline, and it's uniformly radiolucent. And if it gets large enough, it could displace teeth and cause buccal expansion. Now, the main difference between this one and the radicular cyst is that this one, the teeth are vital and it's not on the apex of the teeth. Okay, so this is a dentigerous cyst. This cyst develops from the remnants of the reduced enamel epithelium after the tooth has been formed. So it basically forms around a tooth that hasn't erupted yet or a tooth that's been displaced. Now, most commonly it happens between the ages of 20 and 40. It's 20% of all cysts, and it's most common in the lower wisdom area and the upper canine area. Now, any tooth that's being erupted has a follicular space. If that space exceeds 3 millimeters, then we might point our fingers and think this is a dentigerous cyst. Now, this cyst also is round or oval. It's monolocular. It's radiolucent. It could form around the center, lateral, or it could be circumferential to the unerupted tooth. Now, what it does is that the tooth that it has that dentigerous cyst, it prevents it from erupting. It could also displace or even resorb teeth. If you look at the X-ray on top, you could see that the 3.8 has actually resorbed the roots of the 3.7. And if it's big enough, it could cause facial asymmetry. Now, the odontogenic keratocyst, this cyst develops from the epithelium of the dental lamina instead of the normal tooth that's usually missing from this series. So this one, the age is variable. It's most common between 20 and 40. It's less than 5% of all odontogenic cysts. It usually happens like the X-ray that is shown down there in the posterior body or angle of the mandible. Sometimes it does extend to the ramus. The size varies depending on where it is. So if it's in the mandible, it's usually big. It has uniformly radiolucent. And what it does is that it could cause minimal displacement, but it really doesn't resorb teeth. So if you look at the X-ray, you could see that it's really close to the roots of the 4-5, but it's not really resorbing anything. If there was an impacted, let's say lower 8, it could also resemble a dentigerous cyst. Now, the nasopalatine duct, this cyst develops from the epithelial remnants of the nasopalatine duct or incisive canal. The age is usually between 40 and 60. It's one of the most common non-odontogenic cysts. It affects 1% of the population. Now, if you look, you could notice that usually it gives a heart outline or an inverted teardrop. Now, in the second slide, we'll go over how you could tell if this is a nasopalatine duct cyst or if it's just a really big nasopalatine orifice. Usually this is smooth, well-defined, and well-corticated. You can clearly see all the margins all around. Now, it's radiolucent because sometimes bone destruction happens over there, but if it's superimposed, it could give some radiopacity. Now that if it grows too big, it could cause displacement of the teeth or even palatal expansion. Now, when we're not sure, is this a nasopalatine duct or is it a nasopalatine cyst? If it's greater than 6 millimeters, then most probably it's a nasopalatine cyst, because the foramen usually is oval or irregular, and you could only see the lateral borders of it. It's really not clear apical or even towards the palate. And a cyst tends to be more radiolucent because it's resorbed bone there. Okay, now we're going to talk about bone cysts. So bone cysts, even though they're called bone cysts, they're really not considered cysts because they don't have that epithelial lining. They're usually known as, like, the etiology isn't really known, but it could be caused from trauma. So the children, it usually happens in children or young adults under 20. It's not that common. It could go up to several centimeters like the ones you could see in the X-ray. It has irregular borders that arch in between roots. So the borders are smooth and moderately well-defined. It has minimal or no displacement of the adjacent teeth. It doesn't cause resorption or displacement, and it doesn't cause expansion of the jaw. Okay, now we're going to talk about odontogenic tumors. Now we have the ameloblastoma. So the tumor is an aggressive, but it's a non-metastasizing tumor that originates from the remnants of the odontogenic epithelium of the enamel organ or dental lamina. It usually happens peak age is around 40 years old. It's rare, but it's still the most common odontogenic tumor out there. It usually affects the posterior body of the mandible and ramus, as you can see in the X-ray. It's multilocular. If you could notice on the X-ray, the center part is large, and then you have small monolocular areas around it. The outline is smooth and scalloped and well-defined, and it could cause displacement, loosening, or even resorption of adjacent teeth. If you look at the X-ray, you could find that the 3/6, the distal root, is almost half of it's resorbed. Extensive expansion in all directions, and also maxillary lesions can extend into the parasinus, orbit, or base of the skull. Now, the ameloblastic fibroma, it's a rare benign tumor that originates from both odontogenic epithelium and connective tissue of developing tooth germ. On the X-ray, they resemble ameloblastomas, but they tend to happen in a younger age group. So instead of peaking at 40 years old, this happens with children and adolescents. It's rare. It usually happens in the mandible or the maxilla and the premolar molar region. It's smooth, well-defined, well-corticated, and it's radiolucent, but sometimes it could have internal septa if it's multilocular. It displaces adjacent teeth, causes buccal and lingual expansion of the jaw, and it's 50% chance it's associated with unerupted teeth. Now, the odontogenic fibroma and myxoma, both of them are very similar lesions that are invasive tumors, that are not invasive tumors that originate from the odontogenic connective tissue. Now, if there's excessive fibrous collagen that has been produced, that's what causes the odontogenic fibroma. But if there's excessive ground substance produced, then that's what causes the myxoma. On the X-ray, they're very similar. It's hard to distinguish sometimes. So it's rare. It happens in the posterior mandible or maxilla. And what really gives it a characteristic is that if you look at the X-ray, you could see that the radio densities, it's radiolucent, but you could see as if there's like a string of tennis racket or even X's and Y's. That's how you could tell that that's a odontogenic fibroma or myxoma. The outline is usually smooth and often scalloped. And the adjacent teeth to that lesion are displaced or loosened. Extensive buccal and lingual expansion can occur. Okay, now we have the osteosarcoma. Osteosarcoma is a rare and rapidly destructive malignant tumor of the bone. There's 3 types of osteosarcoma radiographically. It's either osteolytic because there's no neoplastic bone formation. It could be osteosclerotic because there's neoplastic osteoid and bone formation, or it could be a mix of both. Now, this usually happens in young adults. In the X-ray that I showed you, it's quite small. It's the most common primary malignant bone tumor. It's usually in the mandible, but the shape, size, outline, radiodensity, and what it affects, it all depends on the stage of the lesion and whether it's lytic or sclerotic. Now we're going to talk about the squamous cell carcinoma, which is rare, but it's the most common malignant tumor. Now, whenever that squamous cell carcinoma starts on the oral mucosa, it often invades the bone and in the later stages causes destruction and radiolucency. So if you look at the X-ray, what really gives it its characteristic is that the tooth appears to be floating in space. Because what happens is that once that squamous cell carcinoma starts eating up all the periodontal tissue, it could cause displaced teeth, loosened teeth, or having them appear in this shape. Because it causes a lot of destruction, it could lead to something called a pathological fracture. That's when the sarcoma actually eats a lot of bone and makes it weak. And even a minor trauma or anything simple that usually wouldn't break a jaw would break a jaw in this case, just because there's so much bone missing. And obviously it has an irregular outline because, like I said before, anything that's malignant, because it grows fast, it doesn't have a well-defined outline. It's always moth-eaten or poorly defined. Okay, now the secondary metastatic bone tumor, usually this is a carcinoma that comes from either bronchus, breast, kidney, or even the prostate sometimes, because they metastasize to the jaw and then they produce a typical destructive radiolucency of a malignant lesion. It usually happens in patients that are over 40. It's rare, but it's the second most common malignant tumor of the jaw. Now, the shape is irregular. In this one, it looks like Mickey Mouse. The outline, it's also poorly defined because anything that's malignant, it grows fast. It doesn't have a chance to have like a well-defined margin. It's radiolucency, and obviously it causes destruction of the surrounding bone. It could also affect the adjacent teeth by displacing them, making them loose, or even resorbing them. Now, multiple myelomas. Now, multiple myelomas are multifocal proliferations of the plasma cell series within the bone that result in overproduction of immunoglobulins. Now, this happens in adults or middle-aged people. It's not common, but sometimes you have multiple areas, and that could also lead to pathological fractures, because if you have multiple areas of destruction, they're also going to make the borders quite weak. So any weak trauma or anything could actually break the jaw. Now, on the X-ray, like you could see, they're radiolucent, punched out, and have a well-defined border. The lesions could be up to several centimeters in diameter, depending on how long they've been there. Now, Langerhans cell disease, this is quite rare. Now, usually it has multiple lesions throughout the skeleton, occasionally solitary lesions affecting the skull vault, but when we're talking about related to dentistry, it's usually found in the mandible or maxilla posterior to the alveolar process. Now, the first picture, it's a really big one, even though they say that they're usually small, like 1 to 2 centimeters, like the one on the bottom. On the top one, I found one that's actually bigger. So they're monolocular and round. They have smooth and relatively well-defined borders. They're radiolucent. They don't resorb adjacent teeth, but they just destroy everything around it. So if you look at the molars on the first picture, you find that the roots of the sixes are actually still there, but everything around it is missing. So this also, just like the squamous cell carcinoma, it gives an appearance as if the teeth are floating in space. Okay, now central giant cell granuloma. This is a relatively uncommon non-neoplastic mass in the jaw producing an expansile radiolucent lesion. Now, the age it varies, but usually people under 30. It's uncommon. The site usually, like you could see in the x-rays, it's in the mandible or the anterior region of a deciduous dentition, often crossing the midline. Now, the picture that I found on the bottom, it's not quite crossing the midline, but it's really close. Usually they're multilocular, or even it could be monolocular in the early stages. And its characteristic is that if you look at the upper one, it resembles like a honeycomb appearance. Now, the adjacent teeth can be displaced or even resorbed. You could see that from the distal root of the 3-6. Sorry, and sometimes it could even cause expansion, uneven expansion to the surrounding buccal and lingual bone. Now, usually they're divided into two. One of them is non-aggressive, which exhibits slow growing benign behavior. And another one is aggressive, which shows typical features of rapidly growing lesions. Okay, now we're going to talk about cherubism. This is one of the lesions that I talked about that could be specific to a certain age group. It usually happens in children between the ages of 2 and 6. It's rare. Now, this is inherited, but sometimes it could appear spontaneous. On the x-rays, the lesion resemble other giant cell containing lesions. Now, if you could see, they're multilocular. Usually they're bilateral and it's symmetrical. So whatever you see on the left, you see on the right. It could happen in the maxilla or the mandible. Now, the radiodensity, it's usually radiolucent, but you could see radio-opaque septa that divided into a multilocular look. Now, as you can see, it causes gross displacement of deciduous and permanent teeth. You can see that the teeth are all over the place, and it occasionally resorbs teeth. It could also cause extensive buccal and lingual expansion. Okay, now we're going to talk about the aneurysmal bone cyst. Like I said before, despite their name, they're not really cysts because they lack that epithelial lining, but it's more accurately defined as a giant cell lesion. Now, the age is usually adolescents, usually under 20 years old. The frequency is rare. The site is the body of the mandible, just like you could see in that picture. Now, it also has a special characteristic, which is it gives out a soap bubble appearance. You could see that on the right of the x-ray, on the right side of the x-ray. Now, the outline is smooth, moderately well-defined. The adjacent teeth are displaced and rarely resorbed. So you could take a look at the roots. You could still see that they're still there. And buccal and lingual expansion of cortex often marked as ballooning or blowout. Now, this is a fibrocemento-osseous lesion. Now, this isn't really a specific diagnosis, but it's just describing a process. So it's better defined as like a skeletal disorder where the bone is replaced by fibrous tissue, and then that fibrous tissue is replaced by mineralized tissue like bone or cementum. So in the early stages, like you could see in the first x-ray, it shows as if it's a cyst-like radiolucency. But the more time it has, the more opacities that it shows because it's depositing those cementum or bone. And then it tends to have like a radio-opaque appearance. Now, this is one of those lesions that could be specific to a certain ethnicity because based on studies, it usually happens in Black female. The age is middle-aged adults. It doesn't happen that often, and it usually affects the vital incisors. So if you look at the first picture, you might think in the clinic that that's necrotic, but if you actually do a vital test, it's going to be vital. So you might think that it's a periapical cemento-osseous dysplasia rather than a necrotic tooth. They're usually small, up to 5 to 6 millimeters. They're round, monolocular. Sometimes they could be multiple. And like I told you, the radiodensity, it depends on what stage it is. If it's in the early stage, it's going to be radiolucent. Intermediate, it's going to have patches of opacity like you could see in the second and third pick. In the later stages, it's going to be densely opaque, surrounded by a radiolucent line. Now, what this does is that it could discontinue, the lamina dura may seem discontinued, but there's no expansion of the jaw. Sorry, now the florid cemento-osseous dysplasia, it's really similar, also happens middle-aged adults, also affects Black women, mainly based on the studies. Now, the frequency is also rare. You could see that it's similar to the other X-ray, but this one, there's multiple ones of them all around the apices of the bottom teeth. Some of them are still radiolucent, but most of them have that opaque look. So they're basically almost the same. The radiodensity also depends on the stage. Early stage, it's radiolucent. Intermediate stage, it's multiple radiolucencies, but it has increasing radio opacities. And then in the later stages, if you look at like around the 4.6, 4.7 area, you could see that they're mainly radio opaque, but they have some radiolucency around them. Now, they could cause expansion of the affected jaw and can be associated with a low grade of osteomyelitis. Now, the last one we're going to talk about today is something idiopathic. Now, the Stephanie bone cavity, it's a cavity or depression on the lingual aspect of the mandible near the lower border. It's frequently said to contain aberrant salivary gland tissue. Now, the age is adults. It doesn't happen that often. It usually happens at the angle of the mandible, right below the inferior canal, as you can see on the X-ray, but above or involving the lower border. So it's usually 1 to 2 centimeters in diameter. It's round and mononuclear.
Thank you very much, Dr. Ali. That was a very nice summary of the radiolucent lesions. I just only quote one thing. If you went up back when you were trying to talk about, the classification of the radiolucent lesions, and you spoke about if you notice epithelialization, well, you cannot notice epithelialization at radiography. You notice cortication, and that's an indication for cysts rather than epithelialization. Epithelialization is a pathological finding versus cortication is a radiological finding. I do believe you have some questions. I thought you have some questions for us.
Me?
Like for the group, like the poll.
Yes, I did. Sorry, I'm gonna bring.
All right, wonderful. So do you wanna start doing them, please? And then after that, I'll do my own thing.
Okay, so there's just 10 multiple choice questions. I'm just gonna launch it right now. Continue. Is it up? Can everyone see it?
Yes.
Okay.
Dr. Ali, you can see the progress of how many people have voted, and you can share the results once you've seen it. Once there's 24 people that have voted, you should be able to share the results.
Okay, it's still at 2.
Can you guys see my screen?
Yes. The voting is 16 out of 24. I'll just wait for 4 more and then end the poll. Okay, these are the results. Should I go over them?
I think if you can just give me a good general idea, what was the question that people maybe did not answer correctly?
Okay, so let me just take a look. Okay, so the main one, which was close, was which lesion causes the teeth to appear as if they're floating in space? Option 1 was multiple myeloma. Second one was squamous cell carcinoma. 47% of them chose it, which is right. And third one is osteosarcoma. The one that gives that appearance is actually squamous cell carcinoma. But the rest, almost everyone answered them right.
Great. So let's move forward. So
Sure.
guys, I wanna share with you some of the cases. First of all, thank you very much for staying late. I know not all of you are like me working. I'm actually still working, but hopefully everybody will be like me with a stamina. So we are as we go and start working and we get busy in seeing a lot of patients, we tend sometimes to miss certain things and downsize some radiological appearances, and that sometimes can have a very, very bad consequences. So I want to share with you a few of the cases. I'm going to give the credit to Mace. Mace is a wonderful person. I have no doubt that she's going to be the best dentist ever, soon. And, after working with me yesterday, she took the pictures, she put them on the slides because I'm not really that great in technology. But anyways, so we have over here a 28-year-old female who happens to be a hygiene student that was referred to us
Dr. Hassan,
because
interrupt.
during her, can you guys hear me?
Yeah, I'm
All
not
right.
sure if everyone is experiencing the same problem, but are you sharing your screen from your cell phone?
Yes, I am.
Okay, so can I share screen, Fatma? because it is not appearing properly. Can you give me permission?
So Dr. Sally, you want to share it on your screen?
Yeah, as soon as Fatma gives me permission.
You have permission.
Yeah.
Yep, you can go ahead and share.
This one. Share. Can you guys see my screen?
Yes, I can.
Okay.
All
good.
right. So this is
just
case
tell me
number
when
one.
Yeah, okay.
So this is the first case that I was talking with, and a female hygiene student has come to us, which is we can just be fixated only on the PAs, and she wants to be referred to a root canal specialist to assess the possibility of having a retreatment on teeth number 1.6 and tooth number 2.6 that were previously done. And she was seen by the dentist who was there, and he prescribed those PAs. He looked at them and he says he discussed with her that no, you know what, you have a pen, and in order for you to do a root canal, you're going to probably cost you exactly the same as doing an implant. Why don't I send you to Dr. Hassan? You can extract the teeth and have an implant. So a patient come to see me. I looked at the PAs, and how we are going to do that. Can we pick on someone, Dr. Sally? Is that allowed?
You can pick. I can't really move my mouse because then I might click in the
Okay,
wrong
shall we pick?
or-
Who should we pick on? Should we pick on Dr. Ali first?
Sure.
So Dr. Ali, can you describe what you see, please?
Okay, on the 1.6, I see a radiolucent area on the mesiobuccal root, around the mesiobuccal root. And I could see radiolucency also between the, which I think is from the distal root, but it's between the 7 and 6. You could see some radiolucency there as well.
Right. Is it uniformal?
The way I see it is it's pretty uniform.
Right. Is it cortical? Is it corticated?
I can't see that. On, you know what, the one on the mesiobuccal, yes, it is. The one on the distal, I can't really tell.
Okay. What about the 2.6?
The 2.6, let me take a look. There's a large radiolucency around, I think there's 4 roots there, but there's large radiolucency right there. And I see like a really large palatal root that isn't treated, and there's a big radiolucency around it. But
Wonderful.
I can't tell the borders.
So what would your next step would be?
Refer her to you.
Oh, no, seriously. What would your next step would be? Obtain better imaging, maybe?
Yes, maybe a CBCT.
Right. So we didn't have a CBCT in the office, so we took the pan. So maybe Dr. Sally can show us the pan. And here's the pan.
Okay, you could see the one on the 1.6. You could clearly see borders right now. It's corticated, and also the one on the 2.6, it's like really round and well defined.
Okay, wonderful. So you're gonna start to suspect what? Based on your clinical finding and your radiographical images, what will be on the top of your differential diagnosis?
I wouldn't say it's just a radiolucency because of poor endo. I would say that it could be a cyst.
So you would probably call it a cyst, right? What type of a cyst would you call it?
Radicular because it's non-vital.
Right, so radicular cyst associated with previously root canaled or root canaled teeth,
Yes.
right? It's 2 teeth, so what are the odds of being anything else, correct?
Yes, But
Right.
yeah, based
So,
on the information we have, I think radicular cyst is.
all right. And since this area is very close to the maxillary sinus, do you want to really have a better imaging?
I do.
Right. So what's the next step that you want to do?
3D imaging, CBCT.
Wonderful. So Dr. Sally can show us the 3D imaging. Okay, I don't know if she can zoom. I can zoom the pictures. I don't know if you guys can zoom the pictures so you can see it. So here we go, guys. The importance of filling those MB2s, right? So according to the radiology report, it's saying that the radicular cyst is due to the unfilled MB2 canal. And Dr. Sally, can we see the other CT scan, please? Well, that's an incidental finding of retention pseudocyst. That's just an incidental finding. And look how big that one is. So lucky enough, on tooth number 26. Can you describe it, Dr. Ali?
Yes, so it's well defined, it's radiolucent, and you could see the borders clearly. It's quite big and it's right underneath the sinus. So probably
Underneath, do you think you have a loss of the wall or not?
I think the cyst grew slowly and then it just started pushing the sinus up.
Right, but if you look at the well corticated area, it's just
Yes.
uniform also. It's the same thickness as it is. So you're absolutely correct, but still, nevertheless, these things can be extremely thin, by the way. And a lot of time you're going to end up, as you scraping them, you're going to end up with a communication.
Yes, anything that's that close, it's always a risk of
Communication.
yes.
Okay, then maybe Dr. Sally can show us if we have a clinical image. So here is a clinical image, and that is the cyst. So as you may understand, after I extracted the teeth, usually what I usually do, I always like to think that the cortical plate or the buccal plate of bone would be very, very thin. You can gently take it out with a rongeur, a small rongeur. And then as you do that, you can expose the cyst. And here is the way that the cyst looks like. And then later on, you can inculate it. And that's what exactly took place. You do inculate it. Obviously, make sure that your assistant is not going to suction the specimen. All right, of course. And you send it up for the pathology, because the rule of the thumb says if something doesn't belong into the place that it has to be examined by pathology. So that's the rule of the thumb. So do not be tempted just to ignore it just because you think it's a radicular cyst, not to send it by pathology, but you do. Now, would you graft or you wouldn't graft, Dr. Ali?
Are we gonna do an implant there?
Yes, she's a hygiene student and she would love to have an implant, and that's why she was referred to see me to start with.
Yes, I would graft because after you remove that cyst, you're gonna end up with a big cavity and we need to fill it with something.
Would you graft immediately or would you graft after you confirm the pathology?
I would graft after I get the pathology back, make sure it's a radicular cyst, because that one will remove it, it's not coming back.
Wonderful. And this is exactly what we did. So we have done them in 2 stages because we were worried that we're going to end up with a bilateral oroenteral communication. So lucky enough, we did not in both cases. So we have a radiograph that shows up the tooth number 16 following extraction and a graft. So Dr. Sally maybe can show that. And see the area has healed really nicely, and I'm sure that we can place an implant over there. All right, so now we can go to case number 2. So here's a case that I was actually very angry when I saw, because this gentleman has been twice, so a couple of our associates, with a swelling, and each time he came, they gave him antibiotic. The mother did not care too much, and she's just like, at the end, one of the girls at the front desk thought that there's something wrong, so she booked the patient to see me, and the patient presented. This is the clinical picture. Dr. Sally, who should we pick on?
Dr. Fatin.
Dr. Fatin. Oh my gosh. Dr. Fatin, how are you?
I'm good, thank you. How are you?
Okay, great. So can you describe the scene? What do you see?
I see a patient with facial swelling, seems bilateral. The lower lip seems severely swollen too. And
The lower lip is not swollen.
Oh.
Yeah, I'm just gonna give it to you. Right? The lower lip is not swollen.
Okay.
It's just like a natural, racial appearance. It's not swollen at all. What do you think is missing here?
Missing in terms of?
If you look at the frontal view of the photograph, what do you think? You have a loss of what? It's if you went to Alberta, well, Dr. Paul Major would have always told you, look at the nasolabial fold. Do you see the labial fold?
No, it's not.
On the right side? All right. So you've got a loss of the nasolabial fold, right?
Yeah.
Right? And intraorally, you can appreciate the swelling, correct?
Yeah, that's right.
So
yeah.
what's the first thing you will do right now?
Obviously examine intraorally and then ask
Take up the
history.
history, swelling, and the patient told you he had nothing and he woke up with a swelling. Do you like what you hear? He woke up with a swelling?
No.
All right.
I would start suspecting maybe infection, trauma, some.
Okay. Now we obtain imaging. So what's the first step? What's first image that you think we should request?
A panoramic.
Or a PA?
Yeah.
Okay. PA, right?
So there's something.
Yeah. Let's do a PA first. So more definitive, less artifacts. We have a PA, we have a pan. We only have a pan. Here we go. You won, Dr. Fatin. What do you see?
So I do see radiolucency obvious on the quad 1 between the central and the lateral incisors. It seems, it seems quite big, corticated, radiolucent. I would start suspecting possibility of a cyst here.
Okay, so what type of a cyst would you suspect?
Obviously we'll have to do a vitality testing at
Wonderful. That's exactly what we've done, and the teeth are vital. You're absolutely correct. That's what we did. So teeth are vital. Do you want to start suspecting what? Location, right?
Yeah, the location. I mean, it is. It seems like it is at the apex, also extending between the teeth. Are
the teeth displaced?
Yes, they are. Yeah,
they are displaced. And are they between which teeth?
The central and the lateral.
So if you were living in about 20 years ago, you would have suspected what? A terminology that doesn't exist. So what is the type of a cyst that doesn't exist anymore? Globulomaxillary, right?
Yeah, that's right.
So globulomaxillary was a terminology that we used to use back a long time ago, and then we discovered that this is not an entity anymore, right? So there is no such a thing right now in the World Health Organization that will tell you have a globulomaxillary.
Yeah.
correct?
Yeah. Right.
And then we start to change it into what? So what would you suspect in a place like this?
It's
Could be what? Could it be a keratocyst?
yeah. I mean, OKC is always the great mimicker.
Absolutely. It could be an OPC cyst. Could it be a lateral periodontal cyst?
Yeah, that's possible too, because it is
Right.
extent.
Right. What else would you consider?
So you mean next step, or what's the diagnosis? Next
No,
step?
no, the diagnosis. I'm trying to come up with a differential. Without a biopsy, you will never be able to do it, right?
That's right. Yeah.
So what would you go?
So next, yeah, we could definitely consider taking a CBCT or referring.
Absolutely, and which we did, and I'm sure that Dr. Sally will tell you. Show it to you. There's no CBCT, Sally?
No, I'm sorry.
Okay, I'm sorry. Well, we do have a CBCT, and I'm so sorry that I did not share it with you guys. But you know, a CBCT showed that it had invaded the floor of the nose, and the patient was referred to Mount Sinai Hospital, and he's pending the surgery. He hadn't has the surgery yet. Once the surgery is performed, I will update you with the results. But the aim of this is that not to downside things, right? Because unfortunately, this child has had 2 times antibiotics for teeth that are vitals just because of the appearance. And unfortunately, there was no imaging. That was actually scary. That was scary. And that took place among us. Okay, so we need to look at it, and we need to, you know, always like pay a little bit of more attention. Okay, so case number 3, Dr. Sally. Oh, this is my beautiful case. This is my beautiful case. So an 11 years old was referred to me for extraction of tooth number 74, right? The child's been described as uncooperative, have an extreme dental anxiety, runs out of the chair. He reports a little bit of buccal swelling, and intraorally there is a buccal fistula associated with the site of tooth number 74. Can somebody describe what he sees? Who are we going to pick on, Dr. Sally, right now? This is the x-rays that was sent to me.
On whoever you want to.
Rose, how about Rose? I love Rosemary.
Sure. Hello.
Hi, Rosemary.
How are you?
How are you?
Good. How are you?
I miss you. Okay,
I miss you
so
too.
what do you see? What do you see?
Tooth 74.
Mm-hmm.
So it looks like there's some root resorption happening there, I think.
Mm-hmm. Yes, and there's a stainless steel crown.
And a stainless steel crown, yes.
So if you see this image, are you going to be alarmed?
Sorry?
Are you going to be alarmed?
Uh,
The clinical presentation, a scared child, being referred to you to be put to sleep, not because of anything, because he doesn't sit on the chair. He has a little bit of a fistula coming up from tooth number 74, and that's it. That's all you got. Oh, I'm going to add to it. The family is Spanish, poor communication skills. The only person who speaks good English is the child.
so yeah, if there's a fistula, then you would be alarmed because there's an infection.
Yeah, right? There's an infection. Will you be ordering more images?
Probably a PA because it doesn't look like you can see much periapically based on the bite
Wonderful,
wing.
wonderful, wonderful. Okay, so I ordered a pan. So maybe Dr. Sally, want to show us the pan? Here we go. Nice pan, right? So what do you see?
It looks like the permanent tooth underneath is erupting in a concerning orientation, I guess. I don't know.
It's displaced. It's displaced.
Yeah,
Absolutely
displaced.
right. It's displaced. Yeah. What do you see as well?
It also looks like there's a radiolucency around it.
A little radiolucency or a huge,
A large one. Yeah.
huge radiolucency, right?
Yeah.
You barely have little bit of bone at the inferior border, right? If you look at
Right.
it, barely anything, correct?
Yep.
Right.
So thinning of the cortex there.
Yes. So, and it's obviously uniformal and it's obviously corticated, correct?
Yes.
All right, great. And, you know, clinically, what do you think I should ask the child or ask the parents? If I couldn't ask the parents, or does that ask the child? What do you think I should ask them? That is very important in the sake of documentation.
Like when this, I'm not sure.
No, I mean, you would probably think what type of anatomy lives there?
Oh, the mental nerve?
Yeah. So
Yeah.
would you ask them about numbness?
Oh, right. So any like numbness of
Yeah.
the mouth at anywhere.
Yeah, and he's numb in that area.
So it's impinging on the anatomy and mental
Absolutely.
nerve.
On the nerve, right?
Yep.
Okay, great. So what is our next step? Better
Like,
imaging.
better imaging, like get a PA.
Right. Maybe like a cone beam CT scan.
Yeah.
All right, cone beam CT scan. Here we go. Let's read the report together.
So 234 is horizontally impacted. Crown of this tooth is located immediately apical to the residual distal root of tooth 74. The root apex of this tooth is located adjacent to the lingual cortical plate, just lingual to the mid-root region of tooth 35. The periodontal ligament space surrounding the root circumference of this tooth is visualized, which should suggest the absence of radiographic sign of ankylosis. The cystic lesion has enveloped the crown of tooth 34, excuse me, as well as the coronal third of its roots, but there are no signs of secondary resorption. This tooth has not caused any resorption of the adjacent teeth 3-5 and 3-3. The crown of the tooth 3-4 can be surgically accessed from the buccal aspect of the alveolar process, just apical to the distal root of tooth 7-4.
Wonderful. But you guys, can you look at the slides and can you look at the cuts and can you, all of us, appreciate up how thin the inferior border is? It's like extremely thin. Like there's not a lot of bone left. This is just like a mandible waiting to break, right? Do we agree? It's just a mandible waiting to break. Nothing left there. Okay, and maybe Dr. Sally can show us the other slide. I'm sorry, I'm doing this with my phone, so that's why maybe. Right, and maybe the other slide. Right. And if you look at the slide that says tooth number 3-4, right? I believe it is the one on your bottom. If you look at the images or the cuts that are at the bottom left. And again, if you can agree with me that there is barely anything left in the mandible, anything left in the mandible, right? So what's your treatment of choice? Hello? Can you guys hear
Yeah,
me?
sorry.
Yeah, what's your
Um,
treatment of choice? Sorry, what's your treatment of choice?
So extraction of the 7-4.
Absolutely.
Um,
Extraction of maybe 3-4 and
Yep.
inculation of the cyst, right?
Right.
Okay, and send the cyst to biopsy because pathology doesn't belong there, right? So anything that doesn't belong to the area has to be sent to biopsy, correct? That's the
Correct.
rule of the thumb. Now, question to all of us. Can we send for a biopsy? Absolutely. Like even if you've seen, like if you've taken something and even if you know that it's a granuloma and you just didn't like it, you didn't like the shape of it, you know, just have some biopsy tubs, speak to the front desk, they'll order it up from Life Labs. You get into the habit of leaving it. You're probably going to become a little bit more adventurous, especially like, you know, removing up fibromas, remove fibroepithelial polyps, even if you know for a fact there's a fibroepithelial polyp. Fibroepithelial polyp shouldn't be there. When something doesn't belong to the site, it has to be sent to biopsy. That's the rule of the thumb, right? So maybe it's not a bad idea to learn how to fill up the prerequisition forms and how to communicate with the lab. And at the same time, remember that OHIP, this is like a practical point. OHIP does not cover the pathology fees, meaning you always inform the patient that the Life Labs, not us, will contact them and there will be a fee. And I believe the fee for pathology like this is about within the range of about $80. So the patient has to pay the lab about $80. It's just something for you to know about because these things keep coming, right? So we've done that. We have removed it. And I think we have a pan post-operatively, right? Sally probably can show it. Dr. Sally can see it. And it doesn't look that bad. Obviously healing, but definitely better than what it was before, right? Again, better imaging, suspect, ask the right question, take a proper history. You know, we should have identified something is wrong if the patient have told us we're numb, right? The patient told you that he was numb, you would have immediately understood that there's something. And good news about it is the patient's lip feeling came back. So that means that he's not going to be numb, right? Case 4, we only have 5 cases, guys. So don't worry, 5 cases only. Not going to keep you awake. Okay, so this patient, right? So who are we going to be picking up with? Okay, I know who we should pick up on. Nisreen. Is she on?
Yeah.
Ah, Nisreen, how are
Yes.
you? Describe the lesion.
Good. Hi.
Describe the PA. Look at the PA. Dr. Sally, don't let her cheat. Okay, Nisreen, describe the lesion.
Yeah, it's a well-defined radiolucent area. Yeah, it's on between the 2 centrals.
Right. So what's the first thing you're going to do?
Vitality test.
Teeth are vital.
Teeth are vital.
Yes.
Okay. It's more, one of the differentials could be a nasopalatine duct cyst. No.
Okay. All right. One of them will be a nasopalatine, but do you think this is where it is, or it should be a little bit higher?
It should be a little bit higher, right?
Right. Okay, good. And what's as well could be?
I don't think it could be something is inflammatory because the tooth are vital.
Absolutely. Absolutely. So what's your next step?
Maybe a better image.
Yes, better image. So what would you send for?
CBCT, because a
Sure.
pan not gonna be more.
Absolutely. So we send up to a cone beam CT scan.
Yeah.
We send up for a cone beam CT scan. Dr. Sally can show us the outcome. Here we go. And can you please read for us the report?
Okay, there is a well-defined corticated hydraulic mixed radiopaque radiolucent lesion in the anterior maxilla apical to the teeth 1-1 and 2-1. It has a diameter of approximately 8.7 millimeter. It's located anterior to the nasopalatine canal. The anterior cortex of the nasopalatine canal is thinned. The buccal cortex is slightly expanded and thinned. The lesion abuts apical lamina dura at teeth 1-1 and 2-1, but doesn't appear to be caused by these teeth. There are multiple radio-opaque foci scattered throughout the lesion with a density ranging from dentine to enamel. There is a radio-opaque halo near the edge of the lesion. These appearances are most suggestive of classifying odontogenic cyst. Other mixed radio-opaque radiolucent odontogenic lesion, such as adenomatoid odontogenic tumor or classifying epithelial odontogenic tumor, are also possibilities. Biopsy is needed for diagnosis. The lesion is located approximately to 22.3 millimeter apical to the incisal edge of the two teeth 1-1 and 2-1.
Wonderful. So tell me what do you know about AOTs?
AOTs?
AOTs, adenomatoid odontogenic tumors. Is there something to do with who gets it more, what age group, which the location is, and 2/3 of the time, the rule of the 2/3? 2/3 of the time, it's what? Associated with what? With an unerupted tooth. 2/3 of the time, it's appearing up between what? Lateral and the canine, right? 2/3 of the time, it's girls more than boys, right? Anybody who knows more can correct me, please. I'm an old man, I can forget.
I'm not sure.
Right. So how do you treat a calcifying epithelial odontogenic tumor? You inculate it, and is that it?
Yeah, inculation.
And what else? Do you remove about 0.5 millimeter around the margins?
A safety margin, yeah.
Yeah, it's not a safety margin. You remove it so that it doesn't reappear because it's a cyst. So when you talk about safety margins, you're talking about tumors, right?
I mean,
right? So you don't want to have reoccurrence, right?
Reoccurrence.
Yes, of course. So what you do, you kind of decorticate, or you go with a big round burr, like number 8 round burr, and you remove shave around 0.5 millimeter from the inside. This case has not been done yet. Most likely it's going to be done this Friday or next Friday. And I will tell the group when is it going to be done. And by all means, you can contact Dr. Sally. And if you want to come and watch it, by all means, I'll be happy. Okay?
Yeah.
Dr. Sally, we have case number 5. We're nearly about to finish, guys. Nearly about to finish.
Yeah.
So here's the beauty of it. This guy just finished braces. Can you believe it? Just finished braces, came for cleaning. And you know who I am? I asked him, does he have a pan? No. How come he never finished braces and we didn't take a pan? Take a pan from him. So I took a pan and look what I find. Who are we going to pick on, Dr. Sally?
Up to you.
No, I don't know.
Who is with us? Let's see. Your favorite, Dr. Summer.
Dr. Samar, yes. Dr. Samar, what do you see?
I am vaccinated. I can't talk.
It's okay. So you can talk. See what
I
you
took the vaccine in my tongue today.
in your tongue. That's amazing.
So you can't pick somebody else.
Can't pick anybody else. You can know this. You know it. You own it. What is it? What?
It seems to be a dentigerous cyst.
No, but you know what? Before we go and jump into conclusions, the right way to see, describe what we see. So that's exactly what Dr. Ali was saying. Describe what do you see?
It's a radiolucent lesion around the crown of the tooth 4-8.
Yes, exactly. Is it well?
Sorry?
Is it corticated?
It's not clear. Seems to be, yes.
Okay, okay.
Yeah.
And you are going to do an examination, right?
Yes.
Okay, and the examination shows a little bit of an expansion of the buccal plate of bone. Okay, not too much. Right?
Okay. Yeah.
So, and you know, patient tells you, you ask them, have you had any pain? Have you had anything? Patient says, no, I don't have anything. Can you describe for me the relationship to the inferior alveolar canal?
Yeah, it seems very like in the alveolar canal.
Well, we don't talk like this. We can say also,
so close to the alveolar canal.
right.
It's displaced. The alveolar canal is displaced, right?
It is what we can say. There's a deviation of the inferior alveolar canal, and there is a loss of inferior cortex of the canal, correct?
Yes.
Gonna describe it. Okay, so obviously in a normal case scenario, I will tell the patient, we have to get a cone beam CT scan. The patient says, well, I'm so sorry, Dr. Hassan, I've just paid up $5,000 for braces, and I cannot afford $300. Your typical Central Parkway patient. Here's your typical Central Parkway patient, right? He doesn't pay for the cone beam CT scan, Dr. Hassan, and he starts to complain. How come nobody noticed it? How come nobody noticed it before? How come you told me about it before, right? So Dr. Hassan gets a hyperventilation and says, don't worry, we'll do it. So I look at it and I'm going to say, but there will be a biopsy. And he says, the patient says, okay, I'll accept the biopsy fee. And we go, fine. So we are going to have to organize our thoughts. So what do you think the purpose of the treatment should involve? Okay, to go a step backwards, what would be your differential diagnosis in this case?
I think we should do an exam on the other teeth too, to be sure that the 4-7 is healthy.
4-7 is vital.
Vital. Okay.
Right. So what's going to be on the top of your differential diagnosis?
As I said, it could be a dentigerous cyst.
Yes, could be a dentigerous cyst. Exactly. That will be on the top of your. Why do you actually say that?
Because it is surrounding the crown of the 4-8. It's causing displacement.
Yeah, it's a well corticated radiolucency.
Yeah.
Seems associated with the cemento enamel junction of an erupted tooth. You're absolutely correct. And well, after that, what would your second one would be?
After the dentigerous cyst, you mean?
Yes.
Any type of odontogenic cyst?
Mention one, please.
Sorry?
What is the most common thing you would think appear based on, because you remember when Dr. Ali classified it, he said you look at the location, you look at the age, you look at the, So what would you, over here, what would you look? It's the angle of the mandible. So what do you think it could be?
Keratosis?
Keratocyst, wonderful. What's the third one?
Hmm.
The big major three in the angle of the mandible, right?
Yeah, I forgot.
How about an ameloblastoma, right? Could it be? Yes, to a lesser degree, yes. But
Yes.
could it be there? Yes, why not?
Uh-huh.
Okay, great. So now we have, it's all about the purpose. So the purpose is to do what? To inculate up the pathology, send it up to a lab, correct?
Yeah.
And remove the tooth that could, if it was an indigenous cyst, you know, remove the causing agent, which is the tooth, correct?
Mhm.
Now, in this case, would you actually consider removing the tooth after you discuss with the patient? So you discuss with the patient and he says, no, I don't want to be numb.
Okay.
Yeah. What would you do?
Just remove the crown of the tooth and the cyst.
You mean do a coronectomy?
Yeah. I mean, not me, of course. This is
Yes, of course. Yeah, so you do a coronectomy, right?
yeah.
And
This is
you inoculate the cyst, correct?
Yeah. Yes.
Okay, so you do that. So this is exactly what we've done. Okay, and what do you think the pathology came as? At?
I think the integer cyst.
No, it didn't. It actually came as a keratocyst.
Keratocyst. Okay.
So what would you do differently if it was a keratocyst?
No clue.
Would you see the patient? What does keratocyst tend to be? Do you want to see reoccurrence?
Hmm.
Yeah?
Yeah.
Maybe?
Yeah.
Right. So this is what we actually did, right? So we see the patients, we see them, and we take a pan every year and we observe the area, right? So maybe
Okay.
Dr. Sally can show us up the final radiograph. Right? Not bad, eh? Okay, good. So what's the outcome of this treatment? Okay, it was favorable because, you know, that's fine. But imagine if that patient slipped through the cracks and no pan was taken, do you think that was going to be a favorable situation? Do you think we'd have ended up with a bad situation? My only worries is that we should actually look at our patients carefully more and more and more and more. And I know I could be guilty myself because sometimes I can miss things. Nobody's perfect. I totally agree that nobody's perfect. But let's just pay more attention. Like it's all about history examination, special investigations, right? So take the history out of the patient, get yourself into the habit. You can do it fast. I'm always amazed by the medical doctors. When you go to the medical doctor, they'll take your history in about 2 minutes because they only spend 6 minutes. In this 6 minutes, they have to take a history, they have to do an examination, they have to order a special investigation, whether it was radiographs or blood work or things like that, right? And this is how you can come closer to become too close to something like a differential diagnosis or a diagnosis, a definitive diagnosis in some cases. So what the outcome of my presentation is that benign appearances that doesn't scare you can sometimes be hiding some serious problems. And I hope that none of you has to face anything like this in your life. I'll face them all for you. Don't worry about it, right, Dr. Sally? I'll take all the blame. So don't worry about it. None of you will. But please, please, please pay a little bit more attention. That's all we are asking you to do. Okay? And at the end, I would like to thank you. It's 11 o'clock. Do you think everybody's still awake, Dr. Sally, or everybody's sleeping, or what's happening?
I think 99% of them are asleep.
Excellent. We love that. So what is going to be the next topic, Dr. Sally?
It's going to be a continuation. We're going to do the different of radiopacities in the jaw.
Radiopacity? Okay, perfect. Who are you going to pick?
Dr. Malash.
Oh my God, where is he? He's not even today on.
He couldn't attend today.
Right, but he's been informed and everything?
I believe Fatma's taking care of that.
Well, if he's not, we can always pick up somebody else, right?
Sure.
Don't worry. Okay, so you're gonna share the chapter with the group,
on the group.
right? Guys, does anybody have any concerns or anything? If somebody has any concerns, please put it in writing to us. We are there for real, by the way. Me and Dr. Sally, we're always there. And by the way, yes, we may not respond to simple things like, the assistant or the receptionist did not smile in my face during the day, right? We may not, or Dr. Hassan, she doesn't like me, or those things. Yes, we may not respond to this, but believe me, we care about you. We truly do care about you. We want you to excel. We want you to be the best in what you do, for real, by the way, because we take our job very seriously and we take our profession very, very, very seriously. So I want you to just know that we are there for you. We all sometimes can be confronted with a situation. I want to share with you even something that took place yesterday with me, where a patient came to wanting extraction of all her wisdom teeth. Her top 2 wisdom teeth definitely did not need extractions. Harm would have been more than good. If somebody knows me, he knows that taking up wisdom teeth is not a problem of whatsoever. But genuinely, I really didn't see a reason why should I take up completely bony impacted wisdom teeth that are already in the maxillary sinus, just because the patient thinks that this will cause her teeth to come back again because they shifted, and she's 32. So this is not a real reason for taking up wisdom teeth. So please pay attention to these things, right? Obviously, the patient was not happy and situation got bad and they had to call the police to let the patient leave. I'm noticing a trend lately. Unfortunately, we've noticed the same trend back in 2008. For you guys who have been working for a while, you'll know it, you remember it. For you who have worked past 2011 or 2012, this is it. Unfortunately, the last 2 years were not as normal years. How about that? Let me just choose my words very politically. They were not as normal as the rest of our lives. And that has had a huge impact on everyone, including our patients, whether the impact was